Welcome everybody to the sixth in the series of webinars for nurses from the anaesthesia team at Davies. Today Louise Clark will be speaking about pain assessment and analgesia for perioperative pain, and then a question and answer session will follow her presentation. I'm sure most of you have already joined one of these sessions before, but to ask questions you need to type them in as you go along, as you think of them, by clicking on the speech bubble icon that you'll see on the top right hand side of the screen. It's the one with the question mark in, so that they're ready for us at the end of the session. Thanks very much. I'm going to hand over to Louise now and enjoy the session. Okay.
Good morning, everybody. Yeah. Good morning, everybody. Whether you're watching this live or whether you're watching it recorded, I know that a lot more people are now back at work. So welcome to those of you who are actually working this morning and seeing this later on. As Liz said, this is the 6th of 6 webinars related to if you like, patient management through the anaesthetic journey, and the series was designed by Becky, who you'll have heard from earlier in the course. So this fits with previous webinars, and I'll refer back to some of those. So I would suggest if you haven't listened to some of the others, you do that first, because this fits together with them. This morning, we're talking about pain assessment and analgesia for, I've written acute perioperative pain, because there is a difference between acute perioperative pain and then chronic post-surgical pain. So we're going to talk about pain in the acute situation. I've got quite an interest in pain management as well as just anaesthesia. So hopefully you'll get something interesting from this morning. So first question, before we get anywhere near the drugs and the therapies, we need to know a little bit about what pain is and why does it matter what pain is? Well, to start with, we need to think about where does pain come from, pain, the etiology, and also how it's perceived. And when an animal perceives pain, how it then goes on to express that it's painful. Only when we've done that and assessed that can we think about how to treat it. Otherwise, it's really what my old boss used to call random pharmacology. We need to think about how it arises, where it comes from, how the animal is perceiving it, and then think about what we do. So we'll try and go through that in a fairly logical manner. So what is pain? Well, pain is not felt by the nociceptor. Pain is felt by the patient. Pain is not a stimulus and it's not a defined response from the animal. And there's absolutely no relationship between stimulus and response. And as nurses, you'll know that, there are plenty of very stoic Labradors to whom you're doing something which you think is painful and they're being fairly unresponsive. However, if you're a greyhound, everything is painful. So we've got to think about this from the animal's perspective as well. Pain also requires that the animal is conscious. When we say if an animal is anaesthetized, oh, he's feeling that, they're not actually feeling pain because their higher centres are anaesthetized. They may be responding in terms of withdrawal to a noxious stimulus, which suggests that your analgesia is inappropriate, but they're not actually feeling pain. Pain is perceived in the higher centres of the brain, in the cortex, and therefore it's quite a complex experience. If we think about the current definition of pain from the International Association for the Study of Pain, it's the IASP, and I say current definition because this was due to be revised this year or is in the process of being revised. So if somebody talks to you next year, you might get a different definition. But pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So what does that mean? It means, well, unpleasant. So there is a feeling about it. It's an emotional experience. So it's not a stimulus response. It's more complex than that. And the tissue doesn't actually need to be damaged. It may be just that there is a perception that it's likely to be damaged. So that all makes it quite complicated. And to add to that, the IASP put a bit more onto the definition, which says the inability to communicate verbally does not negate the possibility that an animal is experiencing pain, and is in need of appropriate pain relieving treatment. Now, interestingly, this had nothing to do with our patients, nothing to do with veterinary medicine. It was to do with children and other adults that are nonverbal. So for humans who've not been able to communicate, because so much in people about communicating how they feel about pain is verbal. So we have got to think about that as well when we're thinking about how we manage pain in our patients. So as I said, pain is an emotional thing, so it's quite complicated, and it's made up of three, if you like, domains. We've got the sensory discriminative, which is a bit like when, I've just done it, where, which bit hurts, how much does it hurt? And that would be, say, if you burnt your hand on the hob or trapped your finger in the door. I've just done it now, I know which bit of me hurts, and it really hurts. The motivational affective component is the disturbance of how you feel. Do you feel like you're going to vomit? It just feels horrible. So that's the motivational and affective component. The cognitive evaluative bit is a sort of psychological impact, and this is more really related with chronic pain. How does it make me feel? Chronic pain can make animals feel depressed. We're all, though, aware of the animal that's recently had surgery, and you think its analgesia is okay, but it doesn't want to eat. It just looks like it's depressed. The cognitive evaluative component of pain is that kind of bit of pain that we've all seen. So quite clearly not a stimulus response. Equally, pain is always subjective, as I alluded to a few minutes ago. It's a personal experience. Your pain is different from my pain, and pain is what the patient says it is or expresses that it is. And it's quite interesting. The dog on the left is a model. The dog on the right has severe meningoencephalitis. They've both got a look on the face that's telling you that they're painful, but only with thorough assessment can we actually tell a little bit more about how painful they actually are. So we're going to talk a little bit about the etiology of pain. This is quite complicated, and if you want to go and make a cup of tea now, that's fine. Just a couple of take-home points. I don't expect you to remember all of this. I just want you to think about it because it really informs how we use our analgesic agents. So the nociception is the burning your hand on the hob, the nociceptive input, and the perception is what happens when that message goes through all its different processing and is received in the thalamus and the cerebral cortex. That's where perception happens, and there's a big pathway in between. So looking at this pathway in a little bit more detail, if we look from the periphery, this little guy here is a nociceptor. Nociceptors are stimulated by all kinds of things, such as trauma, a blade, so surgery, a burn, thermal stimulus or chemical stimulus, and they exist both what we'd call here somatic, so in the somatosensory nervous system, and they also exist in the viscera, so in the abdominal organs, places like that. And what they do is they serve to change this nasty stimulus of some description, and they turn it into basically an electric stimulus, which is due to the flux of sodium, and that then allows transmission of this stimulus from the site of transduction, so from the periphery, through the small nerves here, through the big nerves to the level of the dorsal horn of the spinal cord. And at this level, you get transferred, basically you get a synapse to another neuron, and then you get the signal transmitted all the way up through the different levels of the spinal cord, through the brainstem, thalamus, and up, as we said, to the high levels of the brain. And the end result of this, all this transmission, is pain, which, as we said, is a conscious multidimensional experience with all these different bits to it. But what is equally important is that this pathway can be modulated, so we can get changes or inhibition of transmission because we have some descending pathways that will actually mitigate the pain transmission, so they'll affect it. And you'll have heard of things like endogenous opioids. When you've endorphins, when you've been, say, running, you get a feel good. they're involved in descending inhibition, serotonin and GABA. So if we look at this diagram, this appears a couple of times later on. It's actually from a Canadian consortium looking at how to explain pain. And we'll come back to it, but you can see the red bits are the ascending pain signal. So we've got flame, we've got a blade, we've got cold, all goes up from the nociceptor through the nociceptive nerve fiber up into the dorsal horn of the spinal cord, where we get this synapsing. And you'll see there's a little thing that says interneurons here. These interneurons can actually be inhibitory, so they can affect the ascending transmission in the spinal cord. And this goes all the way up here to where we said to perception up in these areas of the brain. So in the somatosensory cortex, particularly the thalamus and the prefrontal cortex. You don't need to know that, just in the complex areas of the brain. But you can see alongside that, we've got this descending inhibitory and descending excitatory signals, which actually work all the way through this pathway. And the descending inhibitory signal can actually affect how the pain is transmitted. So this is what we're saying about, you might have heard people say that pain is not hardwired. It's affected by lots of things. So it's not like the wiring in your house. You don't have the same system every day. It can be affected by lots of things. And if you have a very affecting descending inhibitory signal, the pain might never actually reach the brain. Or if this is affected, if you like stopped at any part in the pathway, the pain won't reach the brain. So this is what we're trying to do with our analgesic drugs, which we'll come on to later, and you'll see more of this diagram. So if you've got your cup of tea, to summarize pain transmission, it is complex. Patients, not nociceptors, suffer from pain. There's no absolute relationship between stimulus intensity and conscious perception. They're two different things. And pain is a very personal experience. The individual suffering from it is the one who best can describe how they feel. And that's why we really need to assess pain in order to be able to treat it. So, as well as the fact that we all feel we should, why assess pain? Well, to treat pain properly gives medical benefits. Pain is a nasty thing. It's catabolic. It tends to cause muscle breakdown, and it causes poor recovery from surgery. So even if your surgeons are not really interested in pain management like you or me, they will get animals that recover better from surgery if they're pain-free, because they'll have less cortisol, they'll have better recovery in terms of their cell metabolism and function, so they do better. It's also an ethical obligation. You wouldn't want to be left in pain, and we should never do that to our animals. Same from a welfare point of view. We know that self-report, as I said earlier, is the gold standard. I can talk to you and tell you how I feel. We have to use surrogate scales for animals, and these are incorporating behavioural signs that we think are consistent with animals being in pain. We also know that signs of pain are not consistent. Sometimes animals can be very anxious, and that can look a bit like pain. So really good assessment is important. And one thing that a lot of vets are not aware of, and indeed in people, we know that poorly managed acute pain is the biggest cause of chronic post-surgical pain. And we do have evidence that our patients suffer from chronic pain, certainly after big surgeries. So we owe it to them to make sure that their perioperative pain management is really good, because after all, they didn't consent to surgery, did they? Somebody else consented for them. So we're imposing this painful thing on them, and we need to know that we're doing our best to mitigate that. So first thing with pain assessment, what's normal is good. Remember, all these animals are individuals. What's their personality like? Ideally before surgery. I know that can be difficult if you've got a very short time between admit and the animal going to theatre, and also if an animal comes in as an RTA, as an emergency, or when they're sick. But knowing what their normal behaviour, what their likes and dislikes are, is really helpful, because if we can provide an environment for them that they like, then they're less likely to exhibit anxious and stress behaviour. Another thing that's really useful that we have used for a long time are questionnaires. It serves multiple functions. It lets us know what the animals like and dislike, how they feel about certain things, what their favourite toys are, what for cats, what kind of litter tray they like for dogs, you know, other things that are they sociable, are they not sociable, what do they like doing. It also makes the owners appreciate that you are trying to treat their animal as an individual, and they are really, really useful things, and nurses are much better at vets than interpreting these questionnaires and actually doing it to help the animal so that we're not doing anything to them that they don't like. So in terms of practical assessment, from a nursing perspective, when you're looking at these animals, you're looking at expression of abnormal behaviours, you're looking at altered posture, you're looking at restlessness, looking at hiding, especially in cats. And I do worry that sometimes vets think an animal sitting quietly in a corner is fine when actually they're just hiding and they are really just quite afraid and quite sore. Vocalization, aggression or lack of. Animals will be aggressive because they're extremely painful, because they have no other way of showing or asking for help. Equally, an animal who's normally quite confrontational, if they're not aggressive, that can be a big sign that they're really, really painful, because it can cause profound withdrawal. If they're not interacting with their family, with other either canine members or feline members or other people. And facial expression is really important, and a lot of work has been done on, you might have seen the mouse grimace scale, cat grimace scale, facial expressions, that kind of thing. But the bottom line is that we're best using a validated, and I'll come on to explain what I mean about that, pain assessment scale, because that means that whether I'm in this morning and one of you is in this afternoon and somebody else is on the night shift, whatever our internal judgments and what all our value judgments are, these scales have been assessed in a way that allows that we can all use the same scale and get an appropriate answer. So that is by far the best background to how you assess pain. That said, that does not negate the necessity for nursing skills, because you can interpret the behaviours you're seeing and they don't necessarily fit into a kind of categorical structure. So most of you will be familiar with this because it's been around a long time. It's the short form of the Glasgow Composite Pain Scale, and the download information is at the bottom. And what this is basically doing is asking you to assess the animal, in this case a dog, in a series of different ways, looking at the animal, looking at wounds, painful areas, how they are interacting with that wound or painful area. But if you look at my little thing here, where A, look at the dog in the kennel. Is the dog crying or whimpering? Well, we know plenty of dogs, sometimes breed specific. I know very few Dobermans who won't be quite vocal, and very few Staffordshire Bull Terriers after anaesthesia, even if they've had nothing painful, who are quite vocal. So you need to use your judgment when you're using these pain scores and look at them from a global perspective. But we go through looking at the animal and then interacting with the animal. It's really important that you interact with them. They can sit there quietly at the back of the kennel and actually they're just hoping that nobody will touch them because it hurts so much. So really make sure that you're doing what the assessment scale asks of you when you're interacting with them, and you come out with a number at the end, and depending on how many bits of the scale you've used, because sometimes we don't use section B, it will give you a number and then you get a criterion or get an intervention criteria, which allows you to know whether you should be intervening or not, or at least gives you a ballpark idea of where on the linear scale this animal's pain fits. So dogs have been, as you can see, that scale's been around for over 10 years, and we've looked after dogs from an analgesia perspective quite well, probably because dogs are very expressive, they're quite interactive and they like people. So therefore we can see with their interactions. We know from a study that was done as recently as 2000, which isn't actually that long ago, analgesic agents were not actively administered to over 8 out of 10, nearly 9 out of 10 cats undergoing a surgery. That's pretty awful, and it's fortunately a situation that we no longer experience, but we definitely say that cats are the poor relative when it comes to pain assessment and intervention. It's not until the last couple of years that we've actually had the Glasgow acute pain assessment record. This is the feline version. And it's, as I said, it relies quite a bit on facial expression, and there's a huge amount of work went into looking at different kinds of feline facial expression to determine what it meant, if you like. So this is essentially works in a very similar way to the canine one, and you get a total pain score out of 20, and then it says at the bottom validated intervention level 5+ out of 20. So we know if this animal is scoring 5, 6, 7 out of 20, we probably should do something about its pain. If it's scoring 13, 14, 15, we really must do something, and we need to do it very quickly. And by doing serial evaluations over a period of time, we can then work out if we're doing the right thing for this animal, if their pain scores are falling. Again, though, we do need to be aware that animals maybe, we can get animals who become vocal because they've had opioids, they can become dysphoric. So again, these are not absolutes. You need to use your clinical judgment to determine whether actually does this make sense. I've got a number, but does this fit with the patient that's in front of me? And if we've got a really complex patient that's clinically deteriorating and was making a noise but is now completely unresponsive, that's not a good thing. That's a bad thing. So again, you need to look at that with a judgment call. An animal that is no longer crying but is very flat, that's not a good thing, even though the score looks better. So again, you must use your judgment. In addition, I put this in because it was actually the first of the validated feline multidimensional composite pain scales. And this is the Botucatu one. And Botucatu refers to the university in Brazil that devised this scale. And this is quite, if you just Google or just look at the link on the bottom, and go in, it's a nice resource with lots of videos. Unfortunately, because I'm covering quite a lot this morning, I didn't have enough time to show you lots of videos of cats and how they appear to be expressing pain. It's a really good resource. The only thing I would say about the using the Botucatu scale is that it is quite laborious. It's long and we're all really busy. And it requires the use, if we look in part of it, it requires physiological variables, which we question. We've always questioned how important they are in pain assessment, because often an animal could have a high heart rate because it's anxious or because it's been bouncing around. So we need to be aware that actually this was quite a difficult or a more difficult scale to use. If we just look at pain expression, psychomotor change, physiological variables, and we're looking at blood pressure, we know how awkward it can be to monitor it or to actually measure blood pressure in a conscious cat. It's not something you necessarily want to be doing every 2 hours. So it's a shame because the scale is fundamentally very good, but certainly clinically, lots of people have found that measuring blood pressure is awkward, and people have tried to produce an adaptive score, but it isn't really the correct one. But this is another pain scoring system that is well validated and should be used. So we've got one really good one for the dog and 2 for the cat. I would say that the Glasgow ones are probably the easiest and the best validated. That's just my opinion. Things like the Colorado scale, that's been around for years. The canine one, it is not validated. Don't use it. It's basically something that somebody has suggested, but it hasn't gone through an entire validation process. So we don't know that it actually is correct. So stick to these because they are the easiest and the best. So pain assessment is really important. If we can't assess how much pain the animal's in, we haven't got a clue how we're going to actually treat it. And remember that although, I'm an anaesthetist, I use drugs all the time, every drug has a side effect, and we don't want to use more than we need to use, and we want to use the correct combination to deal with the type of pain we've got. One size does not fit all. Not all pain responds in the same way, and assessing pain properly will give us a good idea as to whether this is what type of pain this is and how we should be treating it. We also want to use regular pain assessment because we want to be able to get feedback from the animal. So if we assess regularly, looking at the animal itself and looking at the pain assessment numbers, then we'll know if we're going in the right direction or not. And sometimes you might find that you've just maybe dropped the drug doses. Maybe you've dropped one drug out of your plan and you've reduced the dose of another one, and that's too much, and the animal actually is saying to you, expressing to you, hang on, I need more. And that's why we need to keep reassessing. So we kind of covered this a bit because it's similar to what are the aims of pain relief, to what are the aims of assessment. But what we're trying to do is make these animals get better and feel better. So as I said before, less cortisol, no chronic pain ideally, make sure that they sleep properly, make sure that they eat properly, make sure that they mobilize properly. All of those will contribute to a really good recovery from surgery. So much of the recovery, how an animal does, is not in relation to the technical skill of the surgeon, but is their general management and making sure that we're allowing them to recover to the best of their ability. So if we think about pain management, we're not just talking about drugs. Drugs are definitely a part of it, obviously, but they're not all of it. So we need to think about nursing, we need to think about surgery, and we need to think about pharmacology or medical treatment. So nursing, it's TLC that nurses do well. Are they being fed how they need to be fed, with what they need to be fed in a method that they need to be fed? So for example, the vast majority of our cats having big procedures, we'll put feeding tubes in. If they don't need them, we can take them out. But if they're not eating, they don't do well, and then we have to think about another anaesthetic to put one in. So what can I do to nurse this patient properly? And that includes nutrition. Supporting injured limbs, making sure they haven't got a full bladder. That can be really uncomfortable, especially in an animal that's not ambulatory. It also predisposes to UTI and other problems. So, that's really important from a nursing perspective. Make sure that it's not like a disco in the recovery ward. Make sure that it's quiet, is calm, and that you can allow an environment that they can sleep in, and to promote sleep. And there's various methods of doing this. That includes using pharmacology, things like alpha-2 agonists help promote sleep. But more than that, it's basically making sure they have quiet time where we're not continually assessing them and we've not got the lights on all the time. And there's a lot of evidence from people in ICU, and we know that with the current pandemic as well, that being constantly assessed and constantly in a light room is really bad for you from a sleep perspective, and they need to sleep. From a surgeon point of view, we want to be as gentle as possible, minimize surgical trauma, minimize tissue handling, avoid nerve damage. It's very difficult to avoid absolute nerve damage because we have nociceptors and tiny nerves everywhere, but we certainly want to avoid as much as possible. And we certainly want to avoid big nerve trunks because that can cause a big problem. And if we're closing wounds, we want as little tension as possible because that will mean that there isn't tension through the musculature and everything else, and that is all very, very well innovated. So a good surgeon, and we have data from this from a couple of studies, makes a lot of difference to perioperative pain. And a lot of the time I work with a superb surgeon, and her patients who've even had pretty big procedures, they're really comfortable because she basically only ever handles each piece of tissue once, and she does everything so gently that people are generally amazed with how comfortable they are, but it shows what a difference a surgeon can make. So thinking about the drugs, pain evaluation and management are inextricably linked. So you've got to evaluate it before you can treat it. You can't just give drugs and assume it'll be okay, because that that's not appropriate. We need to recognise and evaluate. We need to think about multimodal and preemptive or better preventive analgesia. And we need to think about making sure that alongside the drugs, we've got nursing well planned, our surgeon's good, and we need to keep coming back to the patient, re-evaluating and adjusting. So why does this not happen? We all want the best for our patients. Why do we not have a really well managed cases in all circumstances? Well, most vets have a pretty poor understanding of pain pathophysiology, which is why I wanted to run over it very briefly with you. They don't know how we get to a painful patient, and we don't know about different types of pain. Historically, we haven't assessed pain very well, and there's good reasons for that. We've only had the feline assessment tools for a few years, so it's really difficult in the absence of something validated. We're just using our clinical judgment. Fortunately, we've generally moved on beyond pain helps to limit activity post-operatively, but if people are using that argument, there's absolutely no reason to do so. That suggests that their surgical ability or perioperative management of the patient is inadequate. Analgesic agents do have adverse effects. No drug is without side effects, but appropriate, effective multimodal use is the best way to keep the side effects minimal, but be effective at the same time. And I think the clinical pain as a diagnostic aid with advanced imaging, that's less of a problem, but it is true that if we see an animal that's just had a lot of opioid, trying to assess it for neck pain can be really difficult, but that's very much a one-off when we're trying to work out what's going on in the acute situation. So why multimodal? As I said, why lots of drugs? We're looking at different sites in the pain pathway. Different drugs work at different levels, and if we can use multiple drugs at multiple levels, we might be able to basically keep the brain completely naive to the input, and therefore the animal feels no pain at all. So going back to our diagram, if we think about, and this is just shown in a slightly different way from the one before, but it explains what's happening at different levels and which drugs can be useful. So if you think back to the talk that Haida did about pre-anesthetic medication, you can think about why she was talking about some of those drugs and how you fit those into a perioperative pain management approach. So we've got transduction at the nociceptor. So this is how we turn something nasty into a signal that then goes to the brain. So what can affect these nociceptors? Well, this is from human studies, so I'm not including everything, but these here are things that are relevant to us. So if you see it here and it's not here, it just means that I'm not covering everything because we don't have time for that. So what's good at stopping transduction? Well, non-steroidals. And these are bread and butter drugs that we use all the time. And essentially from a pain management perioperative point of view, if they're safe, we should use them. There are many times when they're not necessarily safe, but they're really, really effective at inhibiting transduction and inhibiting what we call peripheral sensitization. So, the usual things, meloxicam, carprofen, robenacoxib, virocoxib, etc. Opioids are good at inhibiting transduction. So methadone, buprenorphine, pethidine, etc. Local anesthetics and tramadol. So if we think about non-steroidals and opioids, are the two big groups that we use a lot perioperatively, as well as local anesthetics, which I will come on to. So we've got some drugs there that we could use. How do we stop the impulse being transmitted? Well, a major one here is a local anesthetic, and we know that, don't we, from our general approach clinically, or from your own personal experience. If you're having dental work, somebody will put local in there and that will stop you feeling the pain. So if we can get local in there, that will basically stop ascending nociceptive transmission and stop the brain being aware of anything happening. So that's another site. Alpha-2 agonists also have an effect here. So medetomidine, dexmedetomidine will have an effect at that level. If we've not stopped things at that level, we're looking at the dorsal horn of the spinal cord. Here, local anaesthetics, so for instance, given epidurally, opioids, alpha-2 agonists, non-steroidals, and NMDA receptor antagonists work particularly at the dorsal horn of the spinal cord, and that's things like ketamine. So ketamine is very, very effective NMDA antagonist, and its main site of action from our point of view, from a pain point of view, is the dorsal horn of the spinal cord. So hopefully we've got lots and lots of targets, and then if we get as far as the brain, then that's not so great. Volatile anesthetics are not analgesics, they just inhibit perception. So imagine an animal just anaesthetized with isoflurane, all this lot's going crazy, but they won't actually feel the pain because they are anaesthetized, but there will be ongoing changes with the entire nociceptive system, which are all bad. So the volatile anesthetics themselves are not analgesic, they just inhibit perception. Opioids, alpha-2 agonists, have a central pain relieving activity, as does paracetamol. Paracetamol probably also has activity in the spinal cord. But now you can see where these different drugs work. We'll go through them a little bit more. I'm not going to go through in massive detail, but we'll go through the non-steroidals, opioids, local anesthetics, and a bit on some other stuff. And you can see at what sites their actions are and a little bit more about how they work, and then how you can fit them into an analgesic approach. But do bear in mind that describing peri-operative analgesic techniques is basically a whole textbook and more. There's a whole textbook just on local analgesic techniques. So it's just to give you a bit of background, and I would urge you to go back to the other lectures, particularly on pre-anesthetic medication and patient management, to see how it fits together. So, as we said, if we look at our opioids to start with, and I'm just going to go through all of these quite briefly, they affect what's happening in the periphery, they affect what's happening in the spinal cord, and they affect what's going on in the brain. They don't really affect transmission, but they affect at the outside edge of the periphery, at the dorsal horn, and in the brain. So, multiple sites of action. They've been in use for a long time. We've got full agonists, things like methadone, which is licensed for cats and dogs, and partial agonists. So they have a ceiling of effect, things like buprenorphine. With full agonists, the more you give, you get a predictable and increasing effect. Things like buprenorphine do have a ceiling of effect, but actually some of them have a bell-shaped curve, but that's not clinically relevant. Side effects tend to follow the same rules, and they pretty much always increase with increasing dose. So the more you give, the more side effects you're likely to see. They're very effective analgesics for inflammatory pain, so that's general kind of surgical pain. They don't work for neuropathic pain, and neuropathic pain, which we don't have time to go into, is basically damage to the nervous system. So if a nerve's been transected or a disc is smashed into the spinal cord, they work for inflammatory pain, but not neuropathic. They will cause sedation, as we all know, and we use that. They can cause dysphoria. At high doses and certain drugs, they can cause respiratory depression. They can cause nausea and particularly vomiting, which can be a bad thing in animals, say with damaged eyes or other problems where we really don't want them to vomit. We tend to want to use OP3 agonists like methadone pre and peri-operatively, and we might want to use something really potent and short-acting as well. So methadone is a synthetic opioid, pretty much equipotent to morphine, less nausea, doesn't cause vomiting. It's very long-acting and cumulative, so we need to be really careful about infusing it. It's not licensed for IV infusion, but it will accumulate. But it's licensed in cats and dogs, and it's very much a very, very useful drug. Pethidine can only be given IM. It has a shorter duration of action and might be useful for animals with things like compromised liver function. So It has a role. We don't use it a lot, and it also stings on injection. Fentanyl and alfentanil, I'm just mentioning very briefly, are potent pure agonists. Fentanyl, as Fentadon, is licensed for our species. And if we're using fentanyl, you should use this in preference to the generic. It's more expensive, but it's what we are supposed to be using under the cascade. Very rapid onset, short duration of action, not for standard pre-anesthetic medication, but we tend to use it for acute peri-operative analgesia on the table. It will, however, stop or can certainly affect the respiratory system and can stop animals breathing, which we need to be very aware of. Buprenorphine, it's a partial agonist. It's been investigated at multiple doses. It's something that we tend to find useful, particularly in cats. Some cats will respond better to buprenorphine than to methadone. Cats are a bit funny in that respect. The multi-dose vials can sometimes sting on administration, on injection. It's got quite a slow onset time and a prolonged duration of action, and this is relevant clinically. If you're using buprenorphine, you need to give it time to act, and I'm sure I just talked about that before. Butorphanol is not a particularly good analgesic. It's much more of a sedative. It may have use as an analgesic in small pets, exotic species, birds. That's not really what we're going to talk about today, but I would not consider it a good analgesic at all. If I have an animal that's painful, I wouldn't use butorphanol. So moving on, just on the basis of time, local anaesthetics. Going back to our diagram, local anaesthetics are the perfect analgesic. If they can inhibit what's going on at the nociceptor and inhibit impulse conduction, if you can stop all this, then the dorsal horn and all this is never aware that there's anything painful. And so local anaesthetics can be used to massively reduce the amount of volatile agent, or in fact eliminate it, and reduce the amount of other drugs being used. They are what might be termed perfect analgesics. As I said, if we can stop transmission here, all this is completely naive. So it's really nothing's happening negative here at all. The pain transmission is stopped right down here. So lots of different ways of looking at this. Different routes of administration. They can be given by locally, so just like a ring block or a specific nerve block, or regionally, so we could use multiple nerve blocks to affect the whole of, say, a forelimb or a hind limb. Say we're doing a TPLO, if we can block the big femoral and sciatic nerves, that's perfect analgesia. We can use lidocaine only by a systemic bolus or infusion as a very good analgesic, and we can use them epidurally or spinally. So really, really useful drugs and really cheap. So epidural analgesia, really, really effective analgesia. If it's done at the lumbosacral junction, you will get, with local anaesthetic, you'll get a really effective sensory block and some motor block, so really good pain relief. We also sometimes use opioids and alpha-2 agonists, ketamine in epidurals. If you want to think about this, it's something that you need to read up on an awful lot more, but it's just to know that it's there as a technique. But it's not a technique without risk. None of our techniques are without risk, so we need to be aware of that. Big nerve blocks, as I mentioned, potential femoral and sciatic, lumbar plexus, brachial plexus, all these block these big nerves at different levels. So if we can block these big nerves here, the stifle will be completely analgesed and there'll be no ascending transmission. So this is something that we do on a very routine basis, and we're trying to get more and more people in practice to think about, because it markedly reduces the doses of other drugs, provides perfect analgesia, stops central sensitization, and just generally makes things a lot better. And as I said, we can use lidocaine IV, dogs only, not cats. It's a good analgesic. It's also anti-inflammatory given IV, quite a complex mechanism, but it's something we use a lot in things like peritonitis, pancreatitis. Only lidocaine, only dogs, and it requires a liver that is working properly. So if we think about non-steroidals, just briefly, as that other big group, non-steroidals affect transduction, so they affect what's going on right at the nociceptor, and they affect what's going on in the dorsal horn of the spinal cord. I would say use them in all routine cases unless they're contraindicated. They're really effective against inflammatory pain. Many have licenses for chronic use as well, but we need to be cognizant of their side effects. They are not bad drugs. If they're just used incorrectly, they will cause problems. So never use alongside steroids. Don't use in animals that are got problems with their liver, that they've got platelet function problems. Don't use if they're hypotensive. If their kidneys aren't working, they've got liver dysfunction. If they're volume depleted or they've got a GI bleed. All of these are major contraindications to non-steroidal use. And if you come across a patient who's been prescribed one of these, then it's absolutely fine. You should be empowered to say, I'm a bit worried about giving this drug for this reason, because we'd much rather, not have the complication than have to justify where we've done it, where we've had a problem. So paracetamol sort of fits alongside these drugs. It's not a non-steroidal. We can use it alongside these other drugs, but never, ever, ever in cats. It's really good for things like polyarthritis and meningitis. We use it intravenously at 10 mg/kg BID in the short term. You can use higher doses orally longer term, and Pardale contains paracetamol. Again, not enough time to go into it in detail, but it is a useful perioperative analgesic choice. So thinking now about ketamine. Ketamine, as I said earlier, works at the level of the spinal cord. It's an NMDA receptor antagonist, and we use it very, very extensively in spinal surgeries. And we think it's good for neuropathic pain, so pain where there's damage to the nervous system. So I'm not talking about it here at all in terms of a drug that's used in high doses for sedation or in high doses as part of a triple combination. This is a low doses which are used as an adjunct to analgesia, as an adjunct during anaesthesia, and these are pretty low doses. So we're talking about, we normally say 10 micrograms per kilo per minute, or 0.6 mg/kg per hour. So they're low, much lower. If you think about the sedation dose for a cat, you're talking about 5 mg/kg alongside something like midazolam. So again, ask questions about this, ask your vets, but it's a useful perioperative and long-term analgesic, particularly in painful neuropathic type pain. And alpha-2 agonists, I guess finally, Haida will have talked about this in terms of pre-anesthetic medication. Alpha-2 agonists work at the level of the spinal cord, they work affecting impulse transmission, and they inhibit perception, as we know, because they're very potent sedatives. But they will synergize with the opioids really well, and they will provide sedation, but they can really potentiate the analgesia as well. So we tend to use very, very low doses as an adjunct analgesic. This is an off-license use, and it's really important that you know that, but it's something that can really help with analgesic if you're struggling, but only in certain patients. They're not drugs because of the cardiovascular effects that you want to be kind of throwing around. There is a definite risk to using them, and they should be used very carefully, but low doses can really help if an animal is recovering really quite clearly distressed and painful. So we'd be used 1 to 2 mics per kilo of medetomidine as a single dose during recovery from anaesthesia, And that will just allow us time to reassess the analgesia, to maybe get some more opioids on board, to think about what else we should be doing. And for animals that have got ongoing quite high analgesic requirements, we'll often use it by infusion. The doses for cats are very much anecdotal. There is data for the dogs. So that's an incredibly quick 50-minute run through perioperative analgesia. It's really so that you have some understanding of where pain comes from, an understanding of how important pain assessment is, that you need to assess these patients really carefully to do the best you can, to have a plan in place that you can modify, and that plan should be per individual because each individual does respond differently, and have that plan in place so that if when you assess that patient, if the pain score is inappropriately high, you have an available option. You don't want to have to be phoning somebody at home. You don't have to wait till somebody's finished in theatre or whatever. Make sure that your plan allows you to actually have another option if it's needed. And always think about, is the pharmacology appropriate and relevant? Is there a nerve block that I can do? Because if I do a nerve block, I'm going to need a lot less opioid. If I do a nerve block, the animal is going to be much more comfortable in recovery and much more likely to eat. So, you know, it's always going back to thinking about where the pain's coming from. How can I intercept that pain pathway? And what's the best drug to intercept that pain pathway with? Okay, so sorry that was a quick trip through, but I'm sure Liz has been collating your questions, and actually this is what I think about cats. Thank you very much for your time and attention. Thank you, Liz.
Thanks, Louise. That was great, really interesting, and just highlights how important pain assessment and management is when you're providing a holistic approach to your patient care. We've just got a couple of questions. One cropped up when you were talking about client questionnaires. Somebody's asked if we can share a copy of a client questionnaire, and I'll speak to marketing about whether we can perhaps upload something to the website. So that might be possible to do. And then another question has come from somebody who's asking, is butorphanol MAC sparing when used as part of a pre-med for a non-painful anaesthetic, for example, an MRI?
Yes, it is. Good question. Really good question. Yes, it is MAC sparing, and actually we use it quite a lot for a non-painful procedure. So I would definitely say it's a very good sedative and it reduces MAC, and I would definitely consider it as part of a pre-anaesthetic medication for an MRI. It's a good choice. It's probably an appropriate duration in terms of it. It's not going to last hours and hours when you only have maybe a 60 or 90-minute procedure. So yeah, for a non-painful patient alongside something like, depending on the animal, maybe acetylpromazine or a little bit of alpha-2 agonist, or even by itself in a sick patient, then yes, absolutely. You know, in the situation where we're not looking for analgesia, butorphanol is a good choice.
Thank you. Any other questions? Hang on, there's another one just popped in. And there's a bit of a time delay, and I need to work out how. At the moment, Mike, I can't get to see it. Not quite sure why. Sorry about this for the delay. How long does fentanyl last when given IV, please?
How long does fentanyl last? Oh, all these things, there's a kind of caveat that It is dose dependent, and a single dose will last roughly 20 minutes, but fentanyl undergoes extensive what we call enterohepatic recycling. So actually its half-life can be really long. So you need to be careful with using a lot of fentanyl in an animal with a liver that's not working very well. But a single small dose will give you around about 20 minutes of enhanced analgesia, but there's lots of caveats associated with that. But you know, that kind of gives you a ballpark figure that if you're going to give maybe a microgram per kilogram, 2 mics per kilo of fentanyl IV, you probably get in the order of 20 to 25 minutes. And I would say that fentanyl is much more effective in the dog than it is in the cat. We have gone away from using perioperative fentanyl in cats because it just doesn't give the effect that that some of the early studies suggested. But in dogs, 20-ish minutes would be a good kind of number to think about.
Okay, and if someone else is just asking about the pre-op patient questionnaire, and again, we will. I don't think it's there at the moment, but we will talk to marketing about maybe putting a copy onto the website so that then it will be hopefully accessible when you go to if you go to view the webinars again. So you'll have to leave that with us, and if nothing appears, then maybe send in another query about it, but hopefully we'll be able to share those with you. There's one for cats and a separate one for dogs that we would ask owners to complete at admission. So I don't see any other new questions. Give it just a few seconds, there's a little bit of a delay. If you think of other questions subsequently, then I'm sure if you were to email them in, we can organise answers for you. All right, I've got another question here. What do you recommend for patients that wake up disorientated and distressed?
I guess, are we talking about cats or dogs? And are we talking about just disorientation, or are we talking about pain? But that caveat, if it's a healthy, say, for example, it's probably something like a healthy Staffordshire Bull Terrier Spay that wakes up and it's distressed, vocal dysphoric, then we tend to use a very low dose, 1 or 2 micrograms per kilogram of medetomidine, very dilute. So we would dilute that 1 to 2 mics per kilo into at least 5 mils of normal saline and give slow IV to effect. So probably half a microgram per kilogram at a time. And that can be just a bridge to it. Will calm them down. And then you can think, actually, this dog needs some more opioids, or is it just that it's waking up in a ward that's really noisy? Can I turn the lights out? But I wouldn't give that to an animal who's got significant cardiovascular disease, and you do need to check with the vet. But it's a good adjunct, it's a good bridge to better analgesia, but it's not something that you should just be doing. I have been made aware of issues where people have decided unilaterally to do this, and it's not a good idea, especially, and also be aware if this animal has any atipamezole on board, if somebody has antagonized the alpha-2 to wake the animal up, it's not going to work. So you need to think about your what's gone before. So it's a general good idea, but again, as with everything, there are caveats, but it's certainly something that we will draw up. I had a dog late last night, waking up about 9:30, 10 o'clock, and she was known to be just very, very anxious, and she'd had quite a long and very complex, painful procedure, and we drew up a tiny little bit of alpha-2, so some medetomidine, so it was available. As it was, we didn't need it, and the recovery was lovely, but then at least you have an intervention. So it's always something that if you think this animal might have a bad recovery, preemptively plan, say to the vet, if this has a bad recovery, can I administer? And then you've got advance permission, and you're not potentially doing something that could have problems, and the person that's got responsibility for the case is aware that you may do it. So that will be how I would approach it.
Brilliant, thank you. There doesn't appear to be any other questions now, so I would just like to say thank you all for joining us, and thank you to Louise for a brilliant presentation.